Welcome to the 2025 Best of Lung Cancer Special Edition podcast from the Society of Thoracic Surgeons, where we examine the science shaping the future of thoracic surgery. I'm your host, Dr. Erin Gillaspie, and today we're discussing the best new science from the 2025 European Lung Cancer Congress, which brought together a thoracic oncology specialist to discuss and share the latest advancements in lung cancer research and treatment. Joining me today is Dr. Paula Ugalde, an associate professor within the Division of Thoracic Surgery at Brigham and Women's Hospital, as well as an associate professor at Harvard Medical School. She attended and presented at ELCC, and I'm so grateful that you're here today to bring us all of the exciting updates from that meeting.
Thank you. Thank you for that kind introduction, Erin. It's a pleasure to be here with you today.
Excellent. A lot of ground was covered at ELCC this year. A lot of focus on obviously advancing lung cancer research, improving clinical practice. When you think about your time at ELCC 2025 as a whole, what sort of stood out to you as perhaps the most significant new science, or was there a common thread that really sort of wove throughout the meeting that really stood out to you and spoke to you?
Honestly, the second option, a common thread. I feel that we thoracic surgery community are so much engaged in the care of lung cancer patients with our fellow oncologists and radiation oncologists as we've never been. We used to get the referrals, send them back, but now there's so much communication, so much interaction, so much decision making on the back scenes before starting treatment. For me, that was the highlight. It's just the multidisciplinary care of patients with lung cancer.
I love that. I think it's one of the richest things that maybe we don't even talk to our learners about in our field, that working in just thoracic medicine, whether you're in oncology, radiation, radiology, pathology, surgery, it really is a field that demands such complex multidisciplinary management conversations. To me, it adds a huge amount of richness to my practice every day. I really love it. I love that really stood out to you.
Yeah, definitely.
All right, let's jump into some of our topics because I think there's so many exciting things to talk about. Undoubtedly, it has been a year of immunotherapy updates at all of the major cancer meetings this year. We have heard about landmark OS data. We've heard about DFS. We've heard about past CR, MPRs, higher than ever, better than ever. We're bringing much more data in about surgical outcomes, which is so exciting to us as surgeons, patient-reported outcomes, which is a critical importance for our patients. And one of the major topics discussed at ELCC is one that we're all grappling with, and that is the tracking, restaging of patients during that neoadjuvant phase of treatments. I know a lot of the trials have used a PET scan for restaging. A lot of people talking around sort of the coffee tables at conferences, really have moved away from that more towards CT scans. There's a lot of debates ongoing about how we handle all of those nodes that look unusual after those neoadjuvant treatments. We see a lot of lymphadenopathy after immunotherapy, in particular in our patients who are responding. And one of the hot topics that people talked about was, do we need pathologic mediastinal restaging? Tell me a little bit about maybe some of the discussions you heard surrounding this. How do you think about this in your practice on a day-to-day basis?
If we look back to the trials and we take that as, let's say, to set the stage. So what did the trials do, right? They restage patients with imaging tests, with or without PET scan. Everybody had a CT scan. In the practice of medical oncologists, they will always do another scan, either after the two first cycles or after the first cycle, but they will monitor some kind of the response. And then what we gathered from the trials was, if there is no progression, patients were taken to surgery. Now, how do you interpret no progression? So let's say the tumor had 4 centimeters and now has 5. Is that progression? Let's say the patient had 2 mediastinal positive lymph nodes by PET, and those are still there. Is that progression or absence of response? I think that there are so many nuances to that. It's difficult to have a white or black answer, but what I'm gathering from the meeting and in general from the community is that if there is no evidence of cancer progression, if the staging didn't change, if the number of mediastinal lymphadenopathy stations didn't increase, if the tumor didn't become unresectable, then the patient should not go to surgery. Now, when do I restage the mediastinum? I don't always just restage the mediastinum to say yes or no for surgery. I also sometimes restage the mediastinum for prognosis issues because, let's say, recently we treated a patient with mediastinal bulky lymphadenopathy. So this was a patient with a small right upper lobe tumor, adenocarcinoma, but the station 4R lymph node measured 3 centimeters. It was the only PET positive lymph node, and mediastinal staging confirmed that he was station 4R and 10 positive. We discussed this thoroughly, and we decided to give him the chance of neoadjuvant treatment. First CT scan showed good response. Second CT scan and PET scan showed excellent response. Sometimes I will do the mediastinoscopy prior to the resection just to restage the patient and understand the prognosis. Although I have a clear plan in my head, all right, if he's still one station positive, I'll probably proceed with the resection. But if he progressed, I might not do the resection. So in borderline cases, I will say I like to restage the mediastinum.
No, I like that because I don't think there's a perfect answer to this, just like you
Yeah.
said. And there's a lot of challenges with interpreting these scans, right? We know that if we take all the people who have a pathologic response on pathology, like a complete pathologic response, only about 1% of those, a very small percentage, are going to have a complete pathologic radiographic response. We know that some patients will have a little bit of pseudoprogression. It's a little more common with some other cancer types compared to lung cancer. But we also know that we're really activating the immune system, and it changes how the milieu looks that cancer is now living in. We see some nodes become a lot juicier. We send up for restaging, everything comes back negative. It can lead to a lot of consternation. I know in our practice, we were using a lot of PET scans for restaging at first. And actually, we moved away from that and we do CT scans now because there was so much PET avidity related to a good immune response that we actually felt like we were over restaging patients pathologically. So we were sort of doing too many interventions prior to getting to surgery as opposed to getting straight to surgery as part of that plan. And so I really appreciate your description of how are we classifying non-response? How are we making decisions about proceeding then to the OR? Because it's only going to get more complicated as we really truly start enrolling with active clinical trials going on in the space, unresectable patients and very borderline resectable patients, trying to turn them into resection candidates. This question is only going to get harder and harder for surgeons for how we're defining what is the extent of resectability and operability, two things going hand in hand, but how are we tackling some of these complex questions of, restaging and making sure that we are clearing out all residual disease, which is one of the critical things that we're going in there to do.
If we want to optimize treatment for the patients, I think that it makes sense to know if the patient had any level of path response. If there's one thing that we learned with this is that the complete responders and the major responders have a different survival outcome, right? So let's say there is a way, maybe ctDNA, maybe there's going to be a biomarker in the near future, maybe PET scan, maybe any kind of biologic measurement. Yeah. And you're able to know if the patient had or hadn't any response. We know we have now emerging 5-year overall survival from the Checkmate, from Keynote 671, and we have the 4-year overall survival of the Aegean. And the non-responders, their survival curve just goes downhill. Why take those patients through surgery? In my mind, the borderline patients, the ones that have high volume of tumor disease, glued to the aorta, glued to the cava, glued to the heart, potentially infiltrating the diaphragm, the chest wall, pancreas, those cases in which the resectability potentially could affect significantly the quality of life of patient. I think that we have a huge mission in our hands today to really assess if surgery will benefit the patients. In the pre-era where we did chemo and radiation and then surgery, prior to Pacific even, we didn't really have many options, right? So we were all in. We wanted to get it all out. We wanted to do our best. Then we started to have options. Pacific is an excellent option. We can't forget 44% survival is a decent number for patients with stage 3 lung cancer considered unresectable. We have options, and I think that we have to be very careful with the borderline group. So patients with large tumors, I try to assess resectability very carefully, looking at quality of life and the impact of that. But patients with mediastinal lymphadenopathy, I really want to try to make sure that they had some response to give them the benefit of radical resection. So am I restaging everybody? No. But those borderline, yes.
No, and I think that's a perfect way of sort of breaking down and summarizing it. Any piece of data that's helping you to understand, can you get that patient not only safely through an operation, but get out all of their tumor and leave them with a high quality of life to be able to continue to, fight that battle, I think is really, really, really critical.
Yeah. Most of them will need adjuvant therapy, so they need to be in shape for that.
That's exactly right. With even, some of the emerging trials, we're starting to see that past CR creep up. And so there's still question marks existing about whether those patients truly need additional therapy or not. But that's not the majority of patients. Really the highest trials right now are 34.1% for the past CR. So we have a long way to go with that.
We recently published, just as a side note, we recently published and reviewed our series of borderline, so T4 and N2 and 3.
Yeah.
Cases. And, again, it doesn't matter the amount of disease the patient have. If he has a complete response, his survival curve is like a flat line in the 90s.
Yes.
So how do we find them? That's the question.
That's exactly right. That's exactly right. I want to grab onto one of the things you mentioned actually in the case description, because I think this partners and actually transitions us beautifully into the second topic that I wanted to dive into. So as a lot of our listeners know, we are all working on getting familiar and comfortable with our 9th edition of lung cancer staging. If you haven't had the chance to dive into it too far yet, this is the time period of nodes and metastatic disease, and really the landmark change that everybody is navigating is the subdivision of N2. So we have N2A single station, N2B multi-station. And importantly, N2 positivity on its own no longer guarantees a stage 3A, with small tumors. So really changing how we think about some of these cancers. In the contemporary era of chemoimmunotherapy, we see a lot of trials really sort of throwing out some of our old rules of single station N2 disease falling into that resectability category, sort of out the window and saying, hey guys, if we can get a great response, we can get a really pretty decent 5-year survival, regardless of sort of that N2 number of nodes, whether it is microscopic or bulky. Talk to me a little bit about how you are navigating this new era of nodal disease. Where really is that line right now where we should be saying, hey, we shouldn't be crossing over into that area? How are you thinking about resectability for some of these bulkier nodes? And how is the new staging really playing into some of your thought processes here?
So I'm a member of the Staging and Prognostic Factors Committee in the ISLC. I'm actually the chair of the database, and it's our great mission to contribute to the community with the updates of the TNM editions. So when we were at the 8th TNM, a sub-analysis on N1 was done, and there was a signal that the volume of N1 disease could lead to worse prognosis, almost similar like N2. Yeah. We were never able to come to an end with that analysis, and it didn't play to the 9th, so we left that quiet. But then we started looking at the N2 category, and within that group, there was a clear overall survival difference in both clinical and pathologic setting, and that's why there was a change, a suggestion to change the N descriptor, N2 descriptor into A and B. And this is, the role of the TNM classification is prognostication. The role is not to tell you, treat this one this way and treat that one that way. So
Yes.
we know we have more information now that if you have a right upper lobe cancer with a one station positive in the mediastinum, your prognosis is significantly better than one that someone that has two stations on the same side. So, and I think that that's, important for patients to know, important for physicians to know. And for some patients, you will say, well, because the prognosis is so much better, I'm going to go very hard on this patient in terms of the aggressiveness of the treatment planning and all. But that's not going to play out for everybody. So keep in mind that this is prognostication. Now, when we bring that to resectability, I don't necessarily take that element in consideration. And why is that? The reason is because since 2022, when Checkmate trial was first presented and we were finally an option for us, we're back in the game. 2017, we were thrown out of the game because of Pacific. Maybe in the US, a lot of academic centers continue to offer surgery after neoadjuvant, but I was in Canada then, and Canadians, forget it. They were all in for Pacific. I was just barely any neoadjuvant treatment. Anyways, fast forward 2022, Checkmate is presented. We were shocked and happy with what was going. And I gave a lecture recently on resectability on this subject. And the truth is that even between 2022 and today, 3 years, I'm not the same person. So 2022, we were starting the process and we were like, okay, resectable by lobectomy, maybe one lymph node station, intracapsular, fit patient, PD-L1 positive. So a lot of ifs. Fast forward 3 years, honestly, Erin, today I'll tell you, aside from the patients that are N3 with multiple N2 and N1, like extremely high volume of mediastinal disease, we will not consider them resectable. But, this week we had a patient with bulky disease, PCR.
Yeah.
So I presented on this. Is the question resectability? Is that the question? And if you tell me, Paula, yes, that is the question, then I will tell you, okay, can we talk about resectability after 2 or 3 cycles of chemo IO? And then I'll tell you if it's resectable or not. So the MDT bridge is the trial that's coming to show us a new way to assess resectability.
I agree. And I'm actually so glad to be talking to you about this because one of the places that I have been very concerned is a lot of societies with very good intention are working on trying to create guidelines of resectability, surgical, oncology, and it puts these very hard and fast rules around stage specifically. And you can take 100 patients with the exact same stage, and every single one has a different combination of tumor size, location, implications. Is it touching mediastinum? Is it peripheral? Which node is it? Can you get it out? Is it involving, there's so many nuances to the decision of resectability. I worry sometimes that we are missing opportunities for patients, that we are using staging instead of as a prognostication, as a tool, and sometimes potentially slightly incorrectly in trying to force these rigid categories of resectability. I mean, it is the art of medicine after all. But we do have to have some guardrails, right? And so how do we find that sweet spot of kind of really having some guardrails in place to say, all right, this might be really truly too far out of bounds, but in an era where we're seeing these unbelievable responses, I think even some of those guardrails start to get a little bit fuzzy.
During the ELCC, the session on stage 3 and resectability, we had colleagues from radiation oncology and from oncology to discuss this matter. And, in many centers, people incorrectly think that we're competing with our radiation colleagues. And I honestly don't see it that way. That's number one. And then number two, we definitely need to bring the radiation oncologists back to the game, because surgery alone sometimes is not it's not able to completely resect everything, and there could be a chance that there's residual disease. So we need to think about bringing them back to the game. So I have to say that session on management of stage 3, borderline stage 3 non-small cell lung cancer without driver mutation was one of the highlights, and I was happy to join the team for the presentations.
Absolutely. It's a hot area of debate, a hot topic. How do we treat these patients? And I think innovative trials like MDT Bridge, as you mentioned, which, just as a reminder to our listeners, these patients are getting neoadjuvant chemo IO, restaging, and then a decision. These are borderline resectable patients, and a decision. Can they go on to have surgery, or do we pivot and do we go to do a more Pacific style regimen? And can we do that safely, with some original concerns leading away from that, sort of historically, with concerns about immunotherapy prior to radiation? It sounds like some of those fears are going to be eased, especially when we get to hear about more of the data from the ESMO meeting. But really, such an innovative way to think about how we tackle a patient population where sometimes that decision isn't a one moment in time. You need additional data to see how they're going to respond, because if they have a great response, then there's a lot that we can potentially do to help them.
And there's other variable that maybe we surgeons don't like to address, but in all fairness, the surgery that you are able to perform is not the same surgery that your fellow or junior trainee or is able to perform. So the definition of resectability for Dr. Gillaspie is different than from Dr. Ugalde, that for Dr. Smith. And so this concept of willing to put everything in a box is not going to work. And the proof to that is that EORTC did, the survey first, and now they published on several case series on how they would manage. In parallel, the STS, I don't know if you saw that publication, January this year, also published on the management of those cases. And I mean, honestly, there are T1 or T2 with N2 disease, potentially resectable. What is that all about? All those patients were in the trial. Those patients are resectable. So, just a lot of questions.
I agree. And when I saw that publication come out of the STS, I think the whole middle section of potentially resectable really highlighted how controversial of an area this is, that even getting a group of experts together, looking through all of the data, all of the literature, there's still a lot of question about how we define that area. And actually, for better or for worse, I did like that they left that potential in there, for the only reason that, to your point, it is the hands of the person who is going to be doing that surgery, if they are comfortable in doing a safe and effective oncologic operation for that patient in that moment. And if they're not, we have other treatment opportunities that they need to be thinking about.
Yeah, but the thing is that, yesterday I saw a patient that has a T4. What if after induction it comes to a T2 or a T1 or a TX? So, what could have been a humongous operation, maybe it's going to be a lobe. So again, is resectability the question? And if the answer is yes, maybe we should be discussing it after the induction and not prior to the induction.
It's resectability in the setting of response. The double
In my
R's.
presentation, I said ISLC definition of resectability of R0, and that's prognostication. And then there's a dynamic concept, which is resectability after or with or without neoadjuvant treatment.
Yeah, absolutely. Absolutely. Now, you alluded a little bit to predictive modeling and this being a space that there's so much opportunity in. And unquestionably at ELCC, along with many of the meetings this year, even at AATS, a huge topic that everybody is interested in is artificial intelligence.
Yeah. Not just to buy tickets, but the benefit of science.
It has taken, I think, honestly, it's taking just every industry by storm, right? And medicine is one of them. And there's questions about, can we improve pathology? Can we improve radiology? Can we improve decision making? There's people talking about, can this be used in things like radiation to help with treatment planning and predicting impact on surrounding organs? Will this eventually play a role for us as well in predicting response? Talk to me about AI and some of the things that maybe aren't touching surgery right now, but where we're seeing AI sort of sprinkling into the medical field.
Yeah, I really liked during the LCC the session on AI and pathology. That is one thing that I am very, very interested. Actually, I was talking to Lynette Scholl, our lead pathologist here, about that. There is an open trial that it's potentially using AI, and I want to see if we can participate. But the level of assertness of the results is so high using, it decreases significantly the variance. So when I look at the pathology specimen and you look, there's a variation between my interpretation and yours. If you apply AI, that goes basically to zero. And just the standardization of the way that you can read things and interpret. I don't have a lot of experience in the area of radiology. However, I did a study. I don't know if you use 3D for your sublobar resection, but there's this theory that everybody that's doing everybody that is planning for a segmentectomy should do a 3D reconstruction, which I don't, every time someone tells me you have to do this for that reason for every patient, I'm like, really? The question for me was, am I performing bad in my segmentectomies because I don't use 3D? That was my hypothesis.
I like it.
In the Netherlands, that uses AI to reconstruct the chest images.
Cool. All right.
So I've submitted to them, I don't remember now, but like 30 cases of segmentectomies that we did, and then prior CT scan and post-op CT scan. And with AI, they reconstructed the image, and they were able to say if I took out the correct artery, vein, and bronchus.
Love it.
And surprisingly, we did well, but that's not the point. The point is that AI is also a tool to assess the quality of the surgery that you perform. So I have no doubt, to your point, that this is going to be more and more part of our work daily in many, many aspects of what we do.
Yeah, absolutely. Absolutely. I love that several of the meetings now have really targeted path as a place for it. And really, it's not ever to replace people. No one is using AI to replace people. It's to enhance the reads, to enhance the outcomes, and to fill gaps, right? And so a couple of the places I've really heard some exciting sort of data opportunities include things like, hey, not everybody has a cytotech. Not everybody can get ROSE. ROSE can really help to increase assessments of adequacy. Are we going to have enough on biopsy to be able to do all our molecular testing? There are opportunities to use AI. Everybody can prep slides. We can train people to do that. Then AI can evaluate the slide and say, yes, this looks diagnostic. Yes, there is enough cellularity that you're going to be able to get an answer. to those important questions. And so unquestionably, that's great as we start to think about some of our more rural hospitals that might not have as many opportunities to have pathologists at bedside during some of these procedures.
Yeah, I'm happy that the societies are bringing this subject to the scientific programs. And the AATS did it,
Yes.
ELCC did, ESMO did it. So we're seeing more and more presentations on AI, which is great.
Absolutely. Getting incorporated into the medical record systems and unquestionably, really one of the leaders of PAC, I think, was radiology. I mean, they really have been using decision-making tools, predictive modeling for more than a decade now. If we think about Canary and some of the early technologies that came out with sort of nodule predictors, identification on scan, they've really helped to move that needle significantly in the medical field, which is really exciting.
Yeah. And for the screening programs, I think it's going to be key in the future. Because I mean, it's hard when you compare scans after scan after scan after scan. So yeah.
Absolutely. Absolutely. Every single meeting, one of the things that I love, love, love to hear is quality of life for patients. It's a huge topic at all the One Cancer meetings this year. We're reporting on these wonderful outcomes, but we're also making sure that we're holding patient goals at the front and center of our clinical trials, of our treatment regimens. And this, I think, goes hand in hand beautifully when we think about things like length of treatment. And one of the topics that came up at ELCC this year was, should we be treating patients for as long as possible with some of our targeted agents? Do we need to be thinking more creatively about de-escalation just as much as we think about escalation? Paula, give me some of your thoughts on the sweet spot there.
Well, it's a great question. And I have to say, in my mind, I'm not an oncologist, just as a disclosure, but target therapy, I see that in one way compared to the patients without a driver mutation. So patients that have a driver mutation, my question would be, should we stop it? I mean, I would be, we're seeing trials now with osimertinib for 3 years. We're seeing trial with open end.
5 years open end, yes.
So, and I think that for the ALK patients, it's just going to be the same. So that's one lane. I think that should we stop it? I mean, maybe for the early stage, yes, but for the more advanced stage, I would be concerned. Yeah. But the other patients, right? The patients that we did a complete resection, the patients that are having neoadjuvant treatment and have a complete pathologic response. I mean, the tumor is dead.
Yes.
All the viable tumor cells are dead from the lymph nodes and from the lung. What else are we doing? Why are we giving more treatment? Why are we giving 13 months, 12 months of treatment? I don't know. These are trials that are driven by pharma. We need to keep that in mind. It is important to talk to our patients. It's important to assess the toxicity. It is important to understand how they're responding to those treatments. But I would be very much in favor of de-escalation. I'm hoping that the Nadim-2 trial would shed some light on that matter, since they treated patients for 6 months in the adjuvant setting instead of a year. But I don't know. I don't have an answer for that one.
Yeah, it's tough, right? Because a lot of the lengths of treatments are extrapolated from metastatic trials, which is a very different disease setting and sometimes biology. We're thinking about managing patients, different levels of functional status. And so I agree, really thinking creatively about length, what is truly needed to get the patient the best possible outcome and cure is always really critical. And making sure to continue to ask patients, are we meeting your goals? Is this meaningful to you? Is really, really critical.
Our oncologists here at Dana-Farber, they have agreed to not give more adjuvant therapy when patients have a complete pathologic response.
Yeah.
Which I think is really good.
Same here, especially after that OS data that came out of Checkmate 816. Everyone was like, we can stop.
Exactly. It makes sense. It makes
Yeah, it does. It does. All right, Paula, you've given me so much of your beautiful time. I cannot thank you enough. Give me a couple of key take home points that you really loved and took away from this meeting, things that you are most excited about heading into the future.
Heading into the future, I want to make sure that we prioritize the quality of life of our patients and we communicate well with our team, the full team, oncologists, radiation, radiology, thoracic surgeon, nurses, nurse coordinator, everybody like a big football team on behalf of our patients. I think that we have to listen to what the patients want. What is their goal? Is their goal survival? Is their goal cure? Is their goal quality of life? Should we be operating on everybody? We have to listen to the patients. I love the ELCC meeting. I thought it was a small, cozy, very familiar meeting that we talked so much in depth about the care of lung cancer patients from stage 1 to 4, from palliative to curative intent. And it's just wonderful to be part of this large community where we hopefully will change the life of so many patients.
I love that so much. What a beautiful summary of everything. Thank you again so much for your time with us today and keep doing all of that amazing work that you're doing, saving lives.
So do you. Thank you so much for your contribution and congratulations for all your achievements. I think that it's wonderful to have a young female surgeon leading the way as you are, a big role model for all of us. Thank you.
Oh, thank you. You guys, was that not such an exciting conversation with Dr. Ugalde? She is just so extraordinary. Now, I did want to take just a couple of minutes to highlight some other key trials that came out of ELCC this year. Now, I do have to make a confession. A lot of them are in the metastatic space. So those aren't quite as exciting to a lot of us who spend all of our time in surgery because those aren't really touching our patients for the most part right now. However, as we all know, a lot of the drugs that are big hits in the metastatic space are quickly trickling into our neoadjuvant and adjuvant space. So I want to make sure to highlight a few of these key outcomes so that as you guys start to hear more about these drugs, they feel familiar. So let's kick into a couple of these trials. So the first one that I want to touch base on is the Mariposa trial. So the Mariposa trial was a trial that used a couple of new drugs in combination for EGFR mutant non-small cell lung cancer. So we're using amivantamab plus lazertinib, and it was compared with osimertinib for EGFR mutated non-small cell lung cancer. And actually, they were able to demonstrate with this new combination, the Ami-Lazer, that there was a significant overall survival benefit with using this in the first line, which is potentially redefining that standard of care. So we are all expecting that we might start hearing more about amivantamab and lazertinib heading and trickling into especially our locally advanced spaces. The LAURA trial, which we've all heard a lot about, continues to reinforce osimertinib's expanding role as consolidative therapy as well. So still a role, an important role for osimertinib. It is a great drug for our EGFR mutant non-small cell lung cancers, the LA5-8R mutations and exon 19 deletions, being used as consolidative therapy after chemoradiation in patients who are not operable stage 3 EGFR mutant disease. In KRAS G12C, we have a ton of drugs coming down the pipelines for mutated metastatic non-small cell lung cancer. The Crystal-7 trial, the Crocus trial explored innovative targeted immunotherapy combinations. So using adagrasib plus pembrolizumab and using cetuximab and fultorasib, both strongly showing efficacy signals through different although there are some differing toxicity profiles, which we do have to be careful about. So one of the huge things we're seeing and exploring in that metastatic space is figuring out what are some of the key toxicities, how are we managing those effectively to make sure that we're giving patients those really effective treatments, high quality of life, maintaining those high quality outcomes, especially as we think about moving some of these drugs into the earlier stage space as well. Other updates include novel antibody drug conjugates. Those are the ADCs. So Dato-DXd, you've heard us talk about this before. really, really making its way into a lot of spaces. And so we're seeing Dato-DXd in combination with osimertinib from the Orchard study. There was a lot of presentations on strategies to mitigate dermatologic toxicity in the Cocoon trial. Again, really hearing a lot about toxicity and how we manage that. And then, of course, new and emerging combinations in PD-L1 high metastatic space disease. So a lot of really exciting things coming down the pipelines. We're seeing better survival than ever in our metastatic space. And I think unquestionably, we're going to see some of these drugs making their way towards us, both in the neoadjuvant and adjuvant space in the near future. Thank you guys again so much for spending your time with us. For our listeners, you can find out more information and related resources at sts.org and in the show notes. Until next time, I'm Dr. Erin Gillaspie, podcast host for the Society of Thoracic Surgeons. Please continue to follow the 2025 Best of Lung Cancer Science Podcast Special Edition series, now available on all your popular listening platforms, including Apple, Spotify, and iHeart. And please don't forget to follow me on Thinking Thoracic, an STS podcast that offers candid conversations about the latest advancements and challenges in thoracic surgery. The podcast is also available on all your favorite listening platforms. Can't wait to see you guys next time.